Thank you so much, Chris, for that generous introduction, and thank you all for coming. I appreciate it, and I hope what I have to say over the next 45 minutes or so will be enriching. The title of my talk is How Should We Think About Mental Illness? And I realized as I was standing here listening that I may not deliver on answering that question, at least not fully, but I will share some thoughts on the topic. So, change is afoot. We're in the midst of a paradigm shift in psychiatry and clinical psychology. And the ways that we've been thinking about mental illness or psychopathology or mental disorders are poised for dramatic change. And it's strange to be in the midst of a paradigm shift because you don't really know how things will end up. And that can be a little bit disorienting and disconcerting. But I'm here to talk to you about one of the avenues that that people are pursuing, including myself, in terms of how we shift our thinking about mental illness. I have some conflicts of interest to mention here. I don't think they're related at all to anything I'm going to tell you about, but just I'm used to presenting those, so I will. I'm going to start with a case, Mr. L, and he's a typical case that you might see in psychotherapy. And this is a real case, although some of the details have been changed to ensure confidentiality. So he was a white male in his late 40s, married with 2 children, happily married. I met his family, and they were very supportive of him. He was a successful business owner, or had been at least, but he was facing significant legal trouble. And in particular, he knew that in the next couple of months, he had upcoming a major court presentation where he had to defend himself. He chose not to take a plea bargain because he felt so firmly convicted that what he did was not wrong. The issue is that he also suffered from crippling panic attacks. And he knew that if he had to stand up there in front of court and defend himself, he wouldn't be able to do it. And he was afraid that he would, end up passing out in front of the judge and jury. So that was what motivated him to address this issue and brought him into treatment at that time. In talking to him, we went over his history leading up to this, particular treatment. And we could start with high school. And he described his problem starting in high school, where he had his first episode of major depression. He then went to college. During college, he developed chronic worry, something that we might call generalized anxiety disorder. He also had social phobia, or severe social anxiety. He started drinking to cope with these issues, and ultimately, altogether, that led him to drop out of college. But he was pretty entrepreneurial and resilient, and he went on to start a business. He starts a family. But during his early adulthood, he experienced additional episodes of depression. He developed significant panic attacks and panic disorder, and his drinking increased such that he was drinking pretty much every day and throughout the day. As he moved in towards middle age, he actually had managed to stop drinking. He had additional episodes of depression, but then his legal troubles began and the panic attacks returned. So how should we understand Mr. L's mental health? And what are the implications for his treatment and prognosis? Right now, we'll put a pin in that and we'll return to him later. But I think this is the backdrop, and this is the type of thing that you see in the consulting room that motivates the type of research that I'm going to talk to you about today. Because on the one hand, his presenting problem is pretty straightforward and circumscribed, and his complaints are about panic attacks, and we can, thankfully, we can treat that with psychotherapy relatively effectively. But on the other hand, his history of diagnoses would seem to suggest a long-standing vulnerability to bouts of depression and other anxiety disorders. And at the basic level, when we try to understand our patients, we want to ideally have diagnoses that we can use to give them. And when you go see any treatment provider, whether it be for mental health or physical health, what you're most interested in is a diagnosis for them to tell you what is it that is going on to help you make sense of things. So why do we diagnose? One, ideally, is it allows us to select an effective treatment. Maybe it helps us establish prognosis, what we expect for the course of the illness and how it might resolve or not. It allows us to communicate clearly with other professionals if we needed to make a referral, so other people would understand what's going on. And it also allows us to communicate with our patients. So for a variety of reasons, one, they can understand what's going on, they can make informed choices, but also sometimes, especially in mental health treatment, it helps them organize their experience, which can be at times scary and confusing. And finally, and this one is important here too, is with diagnoses, it allows us to identify issues that allows us to research them, to hopefully develop new treatments and help ameliorate conditions at the broad scale. So today we're going to focus on psychiatric diagnosis, and we'll start with a little bit of a history lesson of where we've been with psychiatric diagnoses. So we're going to go back to the middle of the last century, and following World War II, it was clear that there was a need to develop a common nomenclature or a common system of diagnoses for psychiatric diagnoses. And coming off of World War II, the National Institute of Mental Health was just being developed, and there was a lot of additional resources being developed around this issue. And one thing was that was identified right away is that because there was no standard psychiatric nomenclature, depending on which hospital you went to be treated at, you might receive a different diagnosis. And so there was no consistency. And this got in the way of things like treatment providers being able to communicate with each other. And it was also got in the way of doing things like being able to identify how many people out there are suffering from any particular problem, because there was no common shared agreement about what the problems were. And so there was both a need for better data collection and as well as standardizing psychiatric diagnosis. And there was also a part where psychiatry wanted to legitimize itself as a medical discipline relative to other disciplines like cardiology and oncology and the like. It didn't seem like it stood up at the same level. And so the National Institute of Mental Health set about developing what's called the Diagnostic and Statistical Manual of Mental Disorders, or the DSM, and the first edition came out in 1952. The second edition came out in 1968, and the DSM-1 and 2 were full of diagnoses that looked sort of like this. These are actually from DSM-2, but these brief paragraphs were all that described major mental illnesses. So the one up there on the top left was called depressive neuroses, what we would think of today as major depressive disorder or major depressive episode. And down on the bottom right, we have schizophrenia, paranoid type. Both of these diagnoses with slightly different names still exist in the diagnostic nomenclature today, but each one of them has several pages of information associated with them. But back then, these brief descriptions were all that was available. And one thing that I've highlighted there that's interesting about this that I think is important to identify is that there's these explanations for what is causing the problem, what's causing the disorder. So on the top left, we have that depressive neuroses is due to an internal conflict or to an identifiable event, such as the loss of a love object or cherished possession. And for schizophrenia, perhaps because of the patient uses mechanisms of projection, which ascribes to others characteristics he cannot accept in himself. And for those of you who might be more familiar with this area, these are psychoanalytic or psychodynamic formulations of mental illness, and that was the major intellectual influence at the turn of, in the middle part of the last century. And so that is what the DSM-1 and 2 were. They were largely psychoanalytic diagnostic manuals. So where are we now? It seems like that's a big jump going from 1952, 1968, all the way to 2025. But in 1980, there was a watershed moment. There was a major shift, and I would call this the first paradigm shift in how we organize and think about mental illness. When the advent of DSM-3, when it came out, the shift was from these brief descriptions that were sort of open and relatively vague to concrete and operationalized definitions of psychiatric diagnoses that had specific criteria that were hopefully, they tried to be as objective as possible, or at the very least, that they were observable and easy to code. And the reason is that those brief descriptions that I showed you have very poor reliability. People tend to disagree when they read them in how they apply them across people. And so because of that, there was low reliability, and that's hard for both practice and the research enterprise. During that time, following the DSM-1 and 2, there was the rise of empirical research-based psychiatry. So psychiatry has now become its own scientific pursuit. So the hope was to create an even better standardization of clinical and research use, and again, also continuing to legitimize psychiatry as a medical discipline. And also there was a big shift intellectually at that time to move away from psychoanalysis and move towards a more biologically informed model of mental illness. And this really was a fantastic feat to shift this way. And I say DSM-3 through DSM-5, which is where we are now, where there's actually been a text revision. DSM-5 came out in 2013, and there was a text revision in 2022. The reason I say that is that there's been relatively modest changes since then. So for the past 45 years, we've effectively been working under the same model. That's pretty remarkable if you think about it. And if you think about other areas of medicine, and you look back to what was going on 45 years ago, not a lot looks the same. There's been major changes, and so it's quite staggering that it's essentially the same model for the past 45 years. Now, at the time, one of the most influential papers, and has been for a long time, was a paper by Robbins and Gouze that talked about 5 phases for validating psychiatric classification. And this was really what set the tone and set the marker for thinking about psychiatric diagnoses that influenced DSM-3 and is carried through until today. There are slightly updated versions of this. I mean, right now in the DSM-5, I'm a consultant to the DSM-5, and we're using criteria that aren't that different from these. They are more updated, but I think that there's something about seeing the way where the genesis of this start that I think is important. And so the way Robbins and Gouze laid it out is they said, first you need to have a clinical description, so describe the clinical picture of the disorder. Then you need laboratory studies. They were hoping that there would be chemical, physiological, radiological, in other words, the same type of blood tests, for instance, that you would get when you would go to see your primary care physician that would validate the disorder or identify it reliably. So this criterion is really about reliability. Then they wanted you needed to establish it was delimited from other disorders. In other words, that it had to be discrete and separate from other potential disorders. You wanted to conduct follow-up studies to see that it had a specific course that you could use to identify the unique disorder. And finally, you would want to look at familial studies, which these days we would think about in terms of genetic studies. But at the time, this was before both behavioral and molecular genetics had come along, and so really you would look for patterns in families. And these were what you would do to establish the validity of diagnoses. And so you can apply these to the DSM diagnoses today and see how they've fared. Now, starting out with operationalized categories, the diagnoses in the DSM are what we would call polythetic. Polythetic means that something has many characteristics or features in common, but not all. So this is really a latent variable model, and what a latent variable means is that there's some underlying cause that can't be observed that's causing the psychopathology or causing the symptoms. And so there's some underlying disorder causing the symptoms. And to use an analogy here, it's like viral infection. So who here has had COVID? Oh, okay, I was going to say you don't have to raise your hands, but I'm glad that you did. This works a lot better if you have. I have had it too, so you're in good company. Now, who here, when they had COVID, had a headache? Okay. Who here had fever? Who here had cough? Okay. Who here had their pain in their skin such that if you touched your skin, it hurt? Well, I guess that was just for my own personal pleasure. But if you paid attention to this, different sets of hands raised for different criteria. And the reason is that the same underlying cause, the infection with the COVID virus or the coronavirus, leads to different symptoms across different people. And that's the logic of a polythetic criteria set, such that the same underlying disorder isn't going to look identical across people. And so you can allow for some heterogeneity by allowing for there to be different criteria. The logic there, though, is that there is the same underlying pathology that's generating the same, or generating different diagnoses, and that's the main assumption. What does this look like? Well, let's take major depressive disorder. I took this out of the DSM, and I've paraphrased the symptoms slightly so that they're a little bit briefer mostly. But here's how you would go about diagnosing major depressive disorder, is that you focus on it has to be at least 2 weeks long, and it needs, one of the first two criteria need to be present, and these are what we would call depressed mood and anhedonia, or loss of interest and pleasure in things. And then in addition to that, there's a bunch of different criteria. A lot of them are very physiological. They have to do with sleep, weight gain, appetite, energy, etc. Although there are other cognitive and behavioral ones as well. And so the thinking is you need at least one of the first two, and then at least 4 more of the other ones. And so that's how you would, that's what it looks like. Now, since DSM-1, DSM-1 started with a few more than 100 categories of diagnoses in the first edition. And then since then, the number of categories have ballooned over time, such that now we're right about 300. It's hard to actually count the number of categories in DSM-5 and DSM-5-TR based on how some of the rules of diagnosis have changed. But nonetheless, the point is there's been a dramatic rise over time. So the first question we can ask is, are these categories truly categorical? In other words, do they really distinguish individuals who have a disorder from another? And here's where I'm going to start talking about some of the research we do in the lab. So one of the things that we do is we collect these, we go out there and list patients, and we collect symptom counts. In other words, we apply diagnostic interviews or questionnaires and the like, and try to get counts of symptoms that people have. And then we look at those distributions of symptoms and try to see if there's a breakpoint in them. In other words, if there's some separation between people who have a disorder or who would have a disorder by the DSM rule versus people who don't. And so what that might look like are these A, B, C, D. Here's a sort of a variation on the left. The example A is a fully continuous model, meaning that there's no clear break there. And under D on the right is a class-based model. In other words, that there's only distinct people. But we even allow there to be hybrids or blends of this. So B would suggest that there's 2 classes. They're kind of overlapping in the number of symptoms they have, but they're fundamentally different, et cetera. And what we do is we use a variety of quantitative approaches that are listed there. We're not going to go into them, to say which of these is more likely or more plausible in terms of what's generating this pattern of data. And what we find consistently, and it was reviewed by the broad literature of this was reviewed by Haslam et al. In 2020, is that it is a continuous model that describes almost all of the mental disorders in the DSM. In other words, the symptoms that you see across people, in other words, that vary across people, just like height varies across people, right? There's no clear break there. Also like height, there's not tall people and short people. There's a continuous gradation of height in the population. So the notion that there are some sort of diagnosis that you either have or you don't, in the same way that you might have a viral infection or not, doesn't seem to bear out in the data. The next question you could ask is, are these disorders really homogeneous? In other words, if someone has a diagnosis, are they sufficiently similar to each other? Now, in this case, this is basically asking the question of, does a polythetic criteria set make sense? And so, just logically, we know that people are going to vary somewhat in terms of their symptoms, right? You're going to allow for some heterogeneity in that, in the same way that you would allow for there's some heterogeneity in the in viral symptoms. But what you tend to find is that there's a lot more heterogeneity than you would want to see for a diagnosis. In other words, that when someone has a diagnosis, just knowing that diagnosis isn't necessarily informative enough about which set of symptoms they have. And importantly, those set of symptoms make people different enough that it matters. And so it's not just that, okay, you're slightly different from the other individual. It's actually, gosh, you seem to be functioning somewhat differently. Now, there's a variety of ways to look at this, but using some of the similar models to the ones we just looked at, we find different symptom clusters different enough that it would seem that they aren't strongly correlated. You see this sometimes in schizophrenia. You see this in certain other disorders as well. You also find that which pattern of symptoms that people have suggests that some people, even with the same number of symptoms, end up having much more severe manifestations of the disorders. So it's not just a fact that it's all people with one symptom or all people with 2, 3, 4 symptoms are sort of equally severe. Actually, depending on which pattern that you have, you might be more or less severe, more or less impaired in your functioning. So it seems like there's no clear break, but also there's not a homogeneous set of symptoms that we're being tapped into here. Another question is, are they discrete? In other words, do these diagnoses cleanly separate from each other, such that if I give you a diagnosis of major depression, it's meaningfully different from something like chronic worry or social phobia? What we find is that it doesn't seem to be the case. And 80% of the diagnoses out there in large epidemiological samples are going to be what are called comorbid, or they're coexisting. Sometimes people call this co-occurring, because comorbid should really be reserved for 2 things that are completely separate, like an HIV infection and diabetes or something like that. And there's something that's called the 50% rule, such that about half the population at any given year is going to have a psychiatric diagnosis. Among those, half of them are going to have 2. Among that half of those are going to have 3, and so forth. And in clinical samples, comorbidity is the rule, not the exception, such that a large study out of Brown, the MIDAS study that's been running for several decades now, finds that on average, for people who are seeking treatment, have on average over 3 diagnoses, and we'd actually round up to 4 if we did that. So that doesn't seem like it's very discrete. To try and make the point a little bit clearer, so let's do a little math. I think that everyone was eager to come down at dinner time to do math. So the past year rate of depression, now it depends on which study you look at, but I'm pulling these numbers from Kalin et al. 2020, or Kalin 2020. There's a review in the American Journal of Psychiatry. So past year depression rates are 7.1%. Past year anxiety rates of any anxiety disorder are 19.1%. So how many people would we expect by chance alone to have both a diagnosis of depression and anxiety over the past year? 1.4%? Okay, good, your math still works. Yeah, so we multiply 0.071 times 0.191 and you get 0.014 or 1.4%, right? So not many if this was just truly randomly varying and these were unrelated to each other. The actual number is 41.6%. If using the same studies that gave us those numbers. That's higher than 1.4%, quite a bit. And what that suggests is that these things are not cleanly separating people with certain issues from others. We can also look at these longitudinal course studies, and this one's a little bit harder to see, but in this case, we can look at continuity over time, and these are different diagnoses here. The major depression, dysthymia, generalized anxiety disorder, specific phobia, social phobia, agoraphobia. The specific diagnoses don't matter much. So we have wave 1 diagnoses here along the rows, and then along the columns we have wave 2 diagnoses. And what you can see along the diagonal is how stable a diagnosis is across a couple of years. And you get these numbers in the 0.3s to 0.4s. But when you look across off the diagonal, what you start to see is that there are high numbers there, numbers that are approaching some of the diagonal numbers in terms of if someone had a diagnosis of major depression at the first wave, yes, their most likely diagnosis at wave 2 is major depression as well, but dysthymia and generalized anxiety disorder are also pretty high, pretty close, and some of these other disorders are also pretty high as well. This is just a subset of disorders, of course, but the same story seems to be the case across this and other studies. Here's another study coming out of Dunedin down in New Zealand. It's a long-running study over 40 years. And, whoopsie daisy. These Sankey plots are hard to interpret. But what you would, if there was no crossing of diagnoses over time, you would see the same colors over time. And instead, what you see is that people are moving in and out of diagnoses over waves of the study, suggesting that people are not showing one continuous pattern, and rather having one mental disorder puts you at risk for other mental disorders in the future. And that sort of heterogeneity is inconsistent with the notion that these things are sort of clearly demarcating a particular type of psychopathology. So what we have right now with the system that we've had for the past 45 years is we have a set of diagnoses that are both too general and too specific. What that means is that for too general, that means a diagnosis actually captures a heterogeneous grouping of symptoms that can and do vary meaningfully across people. And they're too specific, such that individual diagnoses are often insufficient for capturing the presenting problems of the individual in front of them. Now, if you went up to the engineering school and said, listen, you need to design a new system, the system needs to be both too general and too specific. You would have students complaining, they would be on rate my professor or not, saying my professor's giving me an unfair and an impossible task. I know it's unfair because you can't have something that's both too general and too specific. But nonetheless, we've managed to achieve it in psychiatric diagnosis today. And what that issue is what this is identifying is the fact is that the diagnoses that we have currently for mental disorder are not valid. And they are, overall, it's a poorly organized system. And in a poorly organized system, you can get things that are both too general and too specific. I want to be very clear at this moment. The diagnoses are invalid, but the problems people are experiencing are very real. The psychopathology that is described in the DSM is important to study and important to get right because people do suffer from it. It's just the way that it's organized right now is not doing a good enough job. And so why does that matter? Well, who should you select for a study, for instance, if you want to do a study on treatment? How do you want to organize this? People with a specific diagnosis? Well, I've just shown you that that's not going to identify a homogeneous group of people. What if you want to study genetics? Your genetic study is only going to be as good as the diagnoses you use to select people or the way you identify people in your study. The same goes for fMRI studies, and any other study where what you're doing is identifying people based on their psychiatric problems and then studying them. So this is critical if we want to make advances in how we understand psychopathology with the hope of being able to treat it better and ameliorate this suffering. So how should we move forward? There's a variety of different approaches that have been brought to bear here, and the one I'm going to talk to you about is the one that I'm most strongly affiliated with, which is what's called the quantitative empirical approach. And the quantitative empirical approach, we're going to use advanced statistical models to search for patterns in the data, and hopefully the patterns will tell us about or help us identify more valid concepts or ways of identifying patients or identifying the psychopathology that they experience that will be more useful. It is also based on a latent cause or a latent concept model. And in other words, we're going to take the observed data and we're going to use statistical techniques to try and infer what might be shared causes among them. And this is very similar in logic to the current DSM, but what we're saying is we're going to use the same logic, but we're going to not do a top-down saying, here's how we think the world is organized and or psychopathology is organized and here's what the symptoms are. Instead, we're going to say, here are the symptoms and what are the underlying patterns in those data. And here's what a factor model looks like on the right-hand side here. And I presented it up there with the Greek to hopefully impress you. But it also doesn't, likely not the most intelligible way. And what I can do is to make it very easy is those boxes there with the Y's in them, we can replace those with concepts like low mood, fatigue, sleep. These are things that we can measure directly. We can observe them in people or ask people to tell us about them. And then what the data analytic techniques that we use allow us to infer something from that. So from that, we might infer the pattern of how those are associated with each other in people. We can infer something like a depressed state. And it's basically the same logic, and I'm using a simple example here of depression, which is a long-standing concept, to show that we can do that, but we can do that in much larger and much more complex data sets. So what does this look like in practice? Well, here, this is also a sort of a toy or a small example, but you can see here that there are these, this would be a correlation matrix here, and what these numbers represent is how strongly associated these symptoms are within people. These are, by the way, are made-up data to illustrate the point, and what we can see here is that if you look at this, it's not showing up terribly well, but they're right here, like these, there's strong or higher numbers among these three symptoms, and then there's a high group of numbers among these three symptoms, and then high numbers among these three symptoms. And what that's telling us is those are all strongly associated with each other. But when you look off there and you see the patterns of how, for instance, these three symptoms don't associate with themselves, but associate with other sets of symptoms, see this square and this square, or these three symptoms and these three symptoms in this square, the numbers are much lower. And so what you can do is you subject this to the statistical techniques, and the statistical techniques will pull out these patterns. But we can do this with much larger data sets. This one you can do by eye, which is why I'm using it here as an example. And we might say, okay, this is really capturing something like depression, this is capturing something like thought disorder or psychosis, and this one is capturing something like what you'll find out is we're going to call externalizing psychopathology. But the point is that they have a coherence to them, and the data analytic techniques pull these apart. So what we've been doing, along with others in this group that I'll tell you a little bit about in a second, have been looking at patterns in the data to try to understand how should we organize our diagnoses. And I'm going to tell you about a study that we published a couple years ago in the journal Psychological Medicine. It was led by a graduate student of mine, Whitney Ringwald. And what we did here is we collected 35 different data sets of psychiatric diagnoses. Most of these were epidemiological samples. In other words, they capture large groups of people from the population. And there was over 120,000 people represented in this study. And each of these columns here are diagnoses that people might have. And they're going to, it's already betraying what the answer is going to be a little bit, but what we had is these large matrices of correlations of these diagnoses being fed into the computer that was then going to help us identify which of these go together. Now, these are already organized by 5 domains that go together. And what we have here is these 5 domains, and these 5 domains we refer to as internalizing, and these capture things like mood and anxiety disorders, depression and the like. Detachment, that captures basically disorders that have to do with either being withdrawn from, or on the opposite end, being overly invested or intrusive in your relationships. Thought disorder and psychosis are sort of a very similar terminology, but this has to do with things like schizophrenia and related conditions. Disinhibition captures drug and alcohol use and antisocial behavior. In other words, the thinking is here that this captures an inability to inhibit one's desire to engage in certain types of behavior. And finally, antagonism, which refers to a set of disorders that involve the person being at odds with others and often being in conflict with them. So these 5 broad domains capture a lot of the variance in this. And remember, the variance is sort of how the levels differ across people. For instance, major depressive disorder, which is sort of one of the prime examples of mental disorders that we can think about, has a factor loading here of 0.72, which means the majority of its variance is shared with those other diagnoses. That is, it doesn't stand alone. It's more shared with, in terms of how it gets diagnosed with people who have these other diagnoses than it does uniquely so. We also looked above this. You can take these 5 and they load onto these higher order factors of internalizing psychosis and externalizing that sort of, you can sort of split apart into these 5 before you split apart into these diagnoses. And finally, there's the likelihood that I remember I mentioned that sort of the rule of 50%, or you saw that plot where people are moving in and out of diagnoses over time. What you get is, and there's an intriguing concept of general psychopathology in terms that some people seem to have a liability for having any mental disorder. We can talk about that. It's a controversial topic, but we can talk about it if folks are interested. So what you can see here is going from relatively more specific to more general up and down this pattern here. This is what we would call a hierarchy. And up at the very top, it's very general and undifferentiated, and it gets more specific as we move down. And this was just, I already told you about sort of what those numbers mean, but this is saying that, you know, this, for instance, shares most of its variance with other diagnoses as opposed to standing alone. Now, that was a empirical test in large amounts of data, but a larger review of the literature gave rise to what we call the high top, or the hierarchical taxonomy of psychopathology, which is an organization of psychopathology based on a hierarchy going from general to specific, where, for instance, we start with symptoms, very specific difficulties or problems or that people might have, moving up into homogeneous symptom clusters. These are constructs that are a little bit broader, but they tend to be pretty coherent. And then moving up to there to maybe syndromes or these subfactors that tend to be much broader. And then on to spectra, which are even broader still. And so you can think about the spectra as capturing sort of these broader concepts that might not look the same across people, but they're also identifying that some people have sort of a liability or a risk for developing the more specific symptoms within them, and all the way down to the more specific symptoms. To zoom in a little bit here, we'll focus on internalizing. In part, I'm focusing on internalizing because I have to pick something to focus on. In part, it's the most common, the types of issues that people experience. They include things like distress and fear are the big 2. And it also includes other types of things that people get distressed about, like weight and eating concerns, as well as sexual problems. Somatoform here is, it's in hashed lines like this because it's provisional. We're not sure whether it's separate from internalizing or not. This research is ongoing. But hopefully this zooming in a little bit allows you to see a little bit clearer the type of concepts that are underneath each of these levels of the hierarchy. And so that's how the high top is working, and or how it's organized, and this is what the pattern of data would suggest in terms of how we might want to organize this. So not 300 separate diagnoses that are treated as distinct for the most part. Instead, we can think about this as organized from the specific to the general and organized in these patterns. So what does this buy us? It buys us a few things. One, it's a better match to basic psychology. Each of these domains from the high top, for instance, have very clear links to basic domains of personality. Currently, personality has what's called a 5-factor model of personality. It's basically an empirically derived or a scientifically derived set of domains along which people differ in their basic personality. And at the level of these sort of broad spectra from the high top model, we see that they are mapping on pretty directly to the 5-factor model domains, but they're sort of in the opposite for most of them. So 5-factor model identifies emotional stability. High top looks at internalizing, which has to do with emotional problems and emotional dysregulation. Extroversion from the 5-factor model focuses on how sort of engaged people are and how much positive energy they have and positive emotions. And the high top has detachment, which involves being withdrawn from others and having low positive emotions, etc. The one that is actually organized in the same direction is openness to experience, in other words, being open to new ideas, and thought disorder or psychosis, which includes things like delusions and hallucinations. This one is controversial, but the data would, depending on how you look at it, seems to bear it out. And so one way of thinking about psychosis is that it's in some respects reflects just sort of an extreme openness to experience, such that you are even open to experiences that aren't grounded in reality. The other aspect of this, given that this is empirically derived, is it tends to match genetic results much better. So genetic results for individual disorders, what you tend to find is that their same genes show risk for disorders that fall in the same class or the same domain of the high-top model. In other words, the same, focusing on internalizing as that example, we see that the same genes that put you at risk for something like depression also put you at risk for things like anxiety disorders and other mood disorders and the like. And so high top has a much better job, does a much better job matching genetics. They also match what we find from our treatment studies. So treatments tend to have general effects and work for the same domain of psychopathology. They don't tend to be one treatment for one diagnosis for the most part. And so, for instance, we see that cognitive behavioral therapy and selective serotonin reuptake inhibitors broadly are helpful for internalizing disorders like depression and anxiety. Antipsychotics are broadly helpful for the thought disorders of different types. And certain types of psychotherapy like transference-focused or mentalization-based therapy are useful for the interpersonal disorders, or what you might have known as the personality disorders. Additionally, although I don't have a slide for this, hierarchy allows us to move flexibly up and down the level of abstraction. So how we want to define or describe psychopathology isn't always the same for different contexts, right? So when we're thinking about public health, we might want to think broadly. We might want to think about internalizing broadly, or if we think we want to track something like risk, internalizing might be very good. But when we're working with one individual patient, we might want to focus on the very specific symptoms they have. And that is built in, that shift in how we think about it is built into the high-top model. Additionally, the high-top model is dimensional, and it's not currently set up to differentiate between people who have diagnoses and who don't. This also matches the way treatment works. So if you have psychiatric problems, if you have concerns about your mental health and you go see a treatment provider, it's not like the treatment provider is going to decide whether to give you treatment or not, yes or no. Typically, there's a range or a gradation or a dimension of interventions that they might offer you. They might start with wait and see. They might prescribe a medication. They might do once-a-week therapy. They might do intensive outpatient, several times a week therapy. They might do partial hospitalization on up to inpatient hospitalization. So treatment providers, clinicians, they recognize that there is a gradation of severity, and treatment is already set up to deal with that. There are some, coming up on the end here, there are some implications of this model. So the good news is, in clinical practice, research, well, I've already identified some of these. I was getting ahead of myself. So research shows that clinicians don't actually follow the DSM very closely. They often use it for billing, and that's their number one reason for saying why they use it. Insurance companies follow this. But rather, I think the diagnoses are more of a heuristic. It is useful to know that I'm generally dealing with a depressed patient. But the specifics, when I work with that individual, I'm going to focus much more on their specific presenting problems, not on that diagnosis as if they're not different from any other patient with that diagnosis. And for existing research, I think it's useful if you understand the high-top structure. It helps you interpret the pattern of research. It helps you understand, well, why is it that the same genes that put you at risk for certain types of disorders put you at risk for other types? Well, it's because that pattern of covariation is what's likely identifying some underlying process driving things. However, a major limitation of high-top is that it's descriptive. It's not mechanistic, as we would say. It's not telling us what is pulling these symptoms together or these diagnoses together. Rather, it is just saying that they do. And so moving forward, what we need to do is identify or use this more valid structure to help us identify what the mechanisms are. So we need to reorient our research around this. And I think the implications are moving forward too, that diagnosis-specific studies aren't going to be that useful. And one implication from that is that we need more statistical power to be able to look across diagnoses and include more people to look at both the general and specific in psychiatric symptom presentation. And I think the question is also, from a clinical standpoint, is how can this be implemented to help us understand help us provide more useful treatments for our patients. There are some moves afoot like this. There's a unified protocol, which essentially takes the the treatments that are helpful for the internalizing disorders and sort of lumps them together in terms of modules that you can pick and choose for what your patient might need specifically, but they're all of a similar ilk. So coming back to Mr. L, what we can see is if we take a sort of a high top approach, if we think very broadly, he has very high internalizing. And if you look across his history, he's had a pattern of mood and anxiety disorders of various types over his developmental history. There's also a moderate level of externalizing, and when things get really bad, he can turn to alcohol and can have some problems with using alcohol too much. We can talk about a little bit more specific at the subfactors. Currently in the treatment, he presented with high fear disorders, but he has a history of high distress and high harmful alcohol use. And then even more specifically, we can focus on the components. Currently, he has panic attacks and social avoidance. And by history, he has depression, chronic worry, social anxiety and avoidance, and drinking to cope. And so this would be how we might organize our thinking in terms of a high-top diagnostic picture, not just one diagnosis. And in particular, this is useful for treatment in a couple different ways. One, it doesn't change how we might address the currently presenting issue of the panic attacks. We would still do that with exposure therapy like we would if we were thinking about it for the DSM. But where it was critically useful in his case is providing psychoeducation about the internalizing spectrum, helping him understand that liability for internalizing disorders is a continuum, that we all fall along somewhere, and that he ran hot in that domain, that this was going to be something that he had to contend with probably for much of his life. And knowing that he falls high along that domain allows him to organize his life and prepare for it in certain ways that might be helpful. In the same way that you might find out that you're at a high risk for having a metabolic issue or something like that. If you are in a family that tends to have high blood pressure or high cholesterol or something like that, that helps you decide how you want to eat or exercise or the like moving forward, so you can avoid moving into the problem ranges where you end up having a major issue like a heart attack. It functions very similarly from the logic of high tops dimensions. And so we could work on skills to identify and mitigate stressors moving forward that would push him further along that dimension up into the severe range. And that part really was beneficial, taking that approach. So thank you very much for coming. That's all that I've prepared, and I hope it was informative.
Thank you so much for that. All right, we're ready to take questions. Just raise your hand, please. Okay, we have one at the back.
Hi, thanks for the talk. I came in a little late, so apologies if I missed some context for this question. But looking at a lot of the depression instruments specifically, but somewhat mental health instruments more broadly, I noticed just on my own a lot of, I guess, abstractness. I think that dovetails what you're saying, the DSM criteria, and specifically like lack of a social component, social determinants or political determinants of health, like really any, but, and I remember learning about the Corey Keyes mental health continuum, positive psych continuum. This is a few years ago, but at the time it was the only externally validated one that had any, even just in the long form, social component. Like, it was just, even just in the long form, just two questions, is like, how do you feel about your role in society, and do you think society is getting better or not, on a 0 to 100 thermometer scale?
Yeah.
And that was like the state of the art for, at the time, that was like maybe 10 years ago, but, and there might be something in addition now, but that dovetailed to my mind with maybe the concept of general psychopathology, and what we can learn from that, and looking at objective and subjective components or assessments. You talk about your empirical quantitative of kind of mental illness more generally, including depression, both in what we think of it and then assess it, treat it. But I know it's kind of a broad question, but I'm wondering if that does dovetail in your mind to try to better understand social and political determinants all the way down to treatment.
Yeah, that is a broad question, and hopefully I can provide a helpful answer to it with in the time allotted. So I mean, I could happily prepare a course on that. It's definitely a really interesting question, and so the fact that there sort of seems to be this general liability for mental disorders is something that has become a real flashpoint in the literature. It was something that really entered the nomenclature in the sort of the early teens of this century, and some people call it the P factor, which is a pretty cool sounding name. There is a lot of active debate about what drives it. And within that debate, you find both that there are proponents of viewing it as there's some sort of underlying vulnerability. Brain functioning has been proposed. At the same time, there are also other people who are saying that there's no reason it can't be socially determined. Looking across socioeconomic status strata, looking across things like structural oppression or that sort of thing. Anything that is going to stress a lot of people in a very graded way could also be contributing to that. So the short answer is we don't know what's contributing it, but both things that exist outside the person and things that exist within the person both are on the table as potential causes. I am glad that you mentioned social determinants of psychopathology. I mean, fundamentally, we are a social species, and those are things that we are extremely acutely attuned to. And so the biggest risk factors for things like depression and other internalizing disorders tend to be social stressors. We really get distressed when our social functioning is not working well. Thank you so much for your question.
Hi there, this is a super lovely talk. I'm actually kind of curious about history and then maybe going a little bit into dissemination of this. So I know that at least in cognitive psychology and in studying intelligence, there's kind of this general G factor of intelligence, which kind of goes into like underlying, like spatial reasoning, visual processing, and all of these different forms of maybe more specific intelligence. I'm curious if High Top et al. In kind of the creation of this borrowed maybe some of those kinds of seminal ideas and or in disseminating and in trying to communicate it, you've been kind of also using those kinds of concepts and ideas from cognitive psychologists to communicate.
We didn't borrow the ideas, but we borrowed the method. So this question really gets at the heart of the methodological aspect of this, that factor analysis, which is what, I wasn't really labeling it by name, but that is the statistical technique that extracts these patterns. Yeah, SEM, structural equation modeling, in a sort of a more evolved form. It was developed by Spearman to be able to study patterns of intelligence, and going back to the turn of the last century, so the early 1900s, the aughts of the last century, Spearman was looking at patterns of correlations and basically saying, how do we make sense of this? And he developed factor analysis for this. And that has a long historical tradition in empirical psychology, to applying it to a variety of different things. It was used in personality to generate the Big Five, and it has been used, and it was sort of clinical psychologists, particularly as opposed to psychiatrists, that started using this approach for saying, hey, we're seeing these patterns of things co-varying in psychopathology. Maybe it would be useful to apply here too. And actually, since you asked the historical question, this first started in the 1960s by Tom Achenbach with children psychopathology. And so the notion of things like internalizing and externalizing, with internalizing being sort of problems that you experience internally and externalizing being problems that you express externally, are notions that go back to the 1960s for his seminal work. But they were sort of transported up into adult psychopathology later. Thank you for the question.
Hello. So mine's more of a clarifying question. So when we're looking at the high top model, and it has like borderline personality disorder under like 2 separate categories, is that saying that the disorder can present like completely differently? Is that what that means, or is it?
No, not exactly. And
Okay.
although maybe, yeah, well, yes, and maybe that's the more gracious way to answer that question. So when this pattern here, where you see borderline personality disorders listed under internalizing, as well as under antagonism, and then as well, well, those are the only 2 it shows up with here, but we cut it off sort of things that were too low. And what that is saying is that the concept of borderline personality disorder is really an alloy, or it's heterogeneous, and it is a mix of internalizing and externalizing, or internalizing and antagonism, and also oftentimes disinhibition. And so borderline personality disorder really is the poster child for a heterogeneous concept. It really exists at the confluence of multiple different domains here, and you get a ton of heterogeneity in terms of how it presents. And so if you do things like DBT groups, which is one of the validated treatments for treating borderline personality disorder, you'll be working with 10 individuals. All 10 of them have the same diagnosis, and they couldn't be more different than each other. And yeah, there is something about them that's similar, but there's enough about them that's different that specific label isn't enough to really understand your patient. And that really captures that notion of it's both too general and too specific. Does that?
So I guess, like, in your perspective, would it eventually be like, this is borderline personality, but internalizing, just so like then you would view as internalizing or externalizing, and then you would treat it differently potentially?
Yeah, so great question. The high top approach would basically take a look at the profile, and you say, so this particular individual that I'm working with is high on internalizing, maybe relatively low on antagonism for them, but maybe high on disinhibition, whereas someone else might be high on antagonism, low on disinhibition, but high on internalizing, or something like that.
Okay, thank you.
But that's true of any legacy diagnosis, as we might call them, right? We might think about them in terms of those profiles. And of course, there we're using the broad spectra. They're good shorthands, but we would also could potentially give it more specificity below that as well.
Anyone else?
Hi, Dr. Wright. Sticking with this slide, looking at something like histrionic personality disorder, which has a negative factor loading,
Yep.
I'm curious how you would then apply like research and treatment on the detachment like spectra to a disorder where the factor loading is, that's inversely related to everything else in its category.
Yeah. So I didn't really talk about this because it starts to get into a little bit in the weeds. But one of the debates that's ongoing, or I should say it's an assumption, but it's maybe not fully fleshed out, and so because of that, there's room for diversity of opinions on this. But typically we would think about these as being what are called bipolar dimensions. And bipolar dimensions don't mean like bipolar disorder, manic depressive illness, that sort of thing. What it means is that there's information at both the high end and the low end. And so something like detachment might run from very low detachment to high intrusiveness or something like that. So in other words, people that are very withdrawn versus people that are, really enmeshed and over-involved in other people's lives, for instance. And so you might think about it as a continuum along that. And somewhere in the middle is probably where you want to be, but if you move too far out to the edges, you start to have problems. And so what this is saying is that if knowing someone had a histrionic personality disorder diagnosis would mean they're very not detached. They're very much the opposite.
Right. So then in terms of treatment,
Yes.
like, is it like do the opposite of what you would do with the avoidant and the schizo? You know what I mean? Like,
Yeah. So, right. And so much of what you're working with detachment, so detachment is this sort of blend of low positive emotions and withdrawal. And so depending on exactly how that manifests, you might either be doing things that tries to, basically you get them out, more approach behavior, doing things that are going to generate more positive emotions. So the sort of the poster child treatment for this is behavioral activation, or any other kind of approach, hierarchy where you say, okay, well, if you're worried about engaging there, let's try engaging it. So some sort of exposure therapy. But when it comes to histrionic manifestations, or people who are very not detached, who might be more intrusive, this would be an argument for why it's not necessarily the debate about whether it's truly one bipolar spectrum or not. And here you're going to be working on sort of withholding the impulse of engaging, right? And so you would be talking to an individual saying, I know you really wanted to engage there, but what else could we, it didn't go well, it didn't, end up in the outcome you wanted, so let's talk about what else you could be doing other than trying to engage with people, and basically try to build up some temperance or some breaks so that they're not always trying to engage other people, for instance. It's a stilted example, but hopefully it communicates the point.
Thank you.
Thanks for the question.
Have any more questions? Oh, okay.
Sort of backpacking off that question, in what ways does the bipolar model, or could you just elaborate on the bipolar model for the other facets there, like how you can have more thought disorder and also be problematic with a negative thought disorder dimension?
Yeah, thought disorder is a tough one here, and thought disorder would be a good example of one for which this may not work. So internalizing is just, so you've mentioned thought disorder, but that's hard, so I'm going to pick one that's easier. But one that may not be obvious. So internalizing represents basically systems that are related to threat and fear and negative emotions. And you might think well, wouldn't it be good to just never have negative emotions? And the answer there is also no. You don't want to have so many negative emotions that you don't fear legitimately threatening things, that you sort of blithely move forward. And you might see this, and you really want your people that are leading your country, political leaders, to have some degree of fear and threat detection. This was non-topical. This is an example I use all the time, not just today. But so having too low negative emotions is a problem, because you're not able to appreciate threat and avoid things that are threatening. Antagonism, for instance, that puts you at odds with people, but on sort of the other end, you might end up with things that are more like dependency, and so you end up being overly agreeable to the point where you might agree and go along with things that are harmful to you. So at the other end of thought disorder is, we would typically talk about that as lucidity of thought, and that tends to generally be a good thing. If you link this back up to the basic personality literature, you might start to think about this as being sort of so close-minded or so rigid or concrete in thinking that you might have a hard time sort of engaging with abstract thought and other things that make life rich. Now, we don't tend to see a lot of psychopathology there, that in that domain typically, but in a sort of a theoretical standpoint, that would be sort of where it went. But this is one where it becomes difficult to sort of view this as a bipolar continuum.
I am not from the field, so more of an outsider question.
Great.
Within the data, how do you build in the concept of the patient or the average person? So out in the world, where's the limit of well, I'm just average. I have some of these qualities, but I don't need to see a therapist or something, for instance. You know what I mean? How do you determine that I don't know what the word is within research because I don't have the background, but I'm curious. Do you know what I mean?
Yeah, no, I think so. Well,
Like outside of this system,
Yeah.
what is the percentage of humans that are just outside of it? Meaning like they don't place in here, but their experiences contribute to all of these,
Yeah.
labels and
variability
such.
within there.
Yeah.
Yeah, that's a great question. And a lot of that is the kind of thing that leads to like, well, how do we implement this? When do we decide someone needs treatment or not? So two things really complicate this. One is that humans are vastly different from each other, and that both seems to not matter and also seems to be a good thing, right? So there's lots of ways to solve the puzzle of life, and there's lots of ways to be successful, and it just means that your niche might look a little different from mine, for instance, right? So, and we think about this normal variation in these experiences as our variation in personality, right? So someone can be really extroverted and like, going to the library and giving talks to people and get really excited about that. Whereas other people can feel much more introverted and say, well, I would rather just go to the library and read a book in the stack somewhere and not engage with anyone. And both of those are fine and not necessarily problematic and great ways to be, right? But depending also on which environment you're in, so if you're really extroverted and you're not supposed to be speaking out, that can be a big problem. It can feel bad. It can feel like I really want to be doing something I can't. Similarly, if you're very introverted and you're forced to be in a position where you have to do something like give a talk like this or something like that, it would feel potentially bad. Obviously, this is a little bit of a silly example, but I just want to highlight that one has to do, there's variation in human functioning that's both is a good thing for our species. It doesn't seem to be going away, right? So if this was something that was being naturally selected for, it would be washed out, but it doesn't. Generation after generation gets born, and there's a lot of variability in how we function. And at the same time, that does, intersect with our life situation, such that some people with the same personality might excel in one life circumstance and not in others. And so we've written about how, if you think about this from a basic personality perspective, psychopathology or mental illness or these types of difficulties sometimes emerges when the individual and their environment intersect in ways that are bad matches. Now, at the extremes, you have some environments that are so problematic that no matter who's in there, they're going to be suffering. And you have other people that have such sort of fundamental difficulties with their functioning that it doesn't matter which environment they're in, they're going to have difficulties. But in the middle, there's this really broad range where it sort of depends on, what situation you find yourself in, depending on your personality. And there's really interesting things, like our personality allows us to select into different environments, and people typically do this. They try to find people that are going to have similar interests, or to find jobs that allow them to sort of be who they are. But sometimes there are mismatches there. Sometimes they take a job that's a really bad match because they think that's what their parents want them to. Or they pick the wrong group of friends because they look cool, but they really are bad for them in various ways. So, sorry about that. It's complicated, but that's one set of thoughts that I have in answer to your question. Does that help? Thank you.
For Mr. L, I was thinking about the fact that he wanted to represent himself in court, right? So, I mean, that's a pretty grandiose thought, I feel. And you said that you would have given him exposure therapy during that process. Like, what does that look like for him?
Yeah. So, specifically, he felt that it did not come out of a place of grandiosity. It came out of a place of sort of fundamental. He felt like justice would not be served if he agreed. He felt like what he was being accused of and what he was indicted for was unjust. And so he knew the risk that if he defended himself and it didn't go well, like the outcome would be worse than if he took a plea bargain. But he felt that he couldn't, continue to go on with his life without at least trying to defend himself. And now he wasn't going to he had lawyers, but he wanted to be able to, so just to be clear, but he wanted to be able to stand up there and represent, his perspective and take the stand and say, this is why I think that this is not a fair outcome. And so what did, one thing I'll say is it worked. It worked insofar that he was able to do it, and he was very proud when he came back into therapy and was able to say, I did it, I stood up there, I could feel the feelings coming on, I could feel my scope of vision narrowing, I could feel myself hyperventilating, but I just took a second and used everything we worked on, and it went away, and I was able to, address the court, and it worked out. Unfortunately, he was convicted. But that was, I had no control over that. But what it worked is what we did is a typical exposure hierarchy where we went through and we talked about things, we identified things that would be sort of increasingly degrees of anxiety provoked. I didn't structure that sentence correctly. They were increased in their degree of how much they would provoke anxiety for him and potential for panic. And what we would do is we taught him various ways to, relax and calm down, and then week after week, he would engage in those various things. And so some of them were doing certain things in public or, expressing certain opinions that were sort of potentially to put him at social odds with people and that sort of thing. And eventually, he felt like he was able to handle each of those. And it was a really big test to go in front of a judge and jury and be able to say these things. And so, it was enormously successful, and he felt that it was, and he felt like it worked out really well, and so that part was really gratifying as a clinician.
Any more questions?
Yeah, so I'm not super familiar with the P-factor kind of literature, but at least for like bipolar and for mania risk, we have these scales to assess kind of latent subclinical features and to identify those at risk. Yeah. Is there that kind of work being done for, the P-factor in general psychopathology and recognizing those at risk and then funneling them into these categories?
That's a good question. In that specific way, maybe not exactly, but one of the best markers for it, the best what best might suggest someone is at risk of having difficulties, is the distress scales related to distress, and particularly distress is in its most distilled form tends to be depression and worry. And so if you go to your physician's office these days, they often give you what's called a PHQ-9 and a G87. And so these are, like I showed you, the overlap in diagnoses is 40% in anxiety and depression, and the biggest overlap of anxiety disorders is generalized anxiety disorder. And so part of me, as a psychometrician, as someone who does, build scales and stuff like that, is I think, gosh, we're having people answer 16 questions, and it's basically we're getting one piece of information out of it. I would prefer to see, maybe we give 20 questions, and we have 4 questions each for 5 of the broad domains that we see here, right? That would, if I had my druthers, that's what we would start putting into physician's office. However, in terms of identifying distress and thereby identifying sort of people who are having any kind of difficulty, which is basically what the P-factor sort of is telling us, that there's sort of broad liability for any kind of difficulty, then depression and chronic worry would be what I would do.
Yeah.
So, yeah.
Yeah, that's helpful.
Just curious, there are clinicians that have been, practicing for decades, and they're still practicing.
Yeah.
How do you change the landscape of, with the change in how you treat patients? How do you move the whole profession, I guess, forward?
Yeah, this is very much trying to change the wheels of a car while it's driving. And we can't stop treating people, and we can't have it change overnight. So I'll say that there's been, it differs by field and by clinician. Some are very receptive to this type of thinking, and some are very resistant to it. And so A lot of it depends on sort of your own training and how you've been thinking about it for years. There are many clinicians who are basically like, yeah, this is how I think about things anyway. I don't think about these specific diagnoses. I think about these broad categories or these broad domains, and this maps onto my thinking. Great, I'm glad. If you have some scales or something that helps me, bring some measurement to this type of thinking, that sounds great. We're interested in that. Where there are others who will say, this is completely wrong. Robbins and Gouset were 100% right back in 1970, and there's basically been, this is all fancy, and you've got fancy colors for your pictures here, but they don't really do much to help me work with my patients, because my patients, fit into these diagnostic boxes. Within the past few months, including here at the university, I've had both of those expressed to me. So I don't know what to say other than, some people are open to it and some aren't. And, we do our best to try to present this in a way that's approachable. And we also study things like we present it to clinicians, and we give them surveys saying, what did you find compelling? What didn't you find compelling? We do other things where we study and say, hey, do you find this more useful for understanding your patients than the traditional way you'd approach it? And so that aspect of clinical utility of this model is something that part of that high-top work, that it's a consortium that works together on this, and there's a clinical utility work group that tries to figure out how to make it more clinically useful and improve it. Because if it doesn't translate to the consulting room at some point, then, it really is just a bunch of pretty colors and pictures.
So just to get more specific, are you talking about, social work and psychologists and other types of therapists? I mean, is there patterns in terms of receptibility among that grouping or other groupings?
Yeah, I'd say that there is more hesitance among psychiatry and psychiatrists, and psychologists are on average more open to it. But some of the most scathing papers critiquing this have come from psychologists, and that the calls coming from inside the house. I don't have as good of a sense for what social work thinks about it. I haven't been part of that group that is working to disseminate it in a very concrete way. And so I don't have a sense for that. What I will say is that as a consortium, we're very interested in trying to get more people from different backgrounds and different clinical backgrounds to come to the table and join. Because, this is the kind of thing that if it were to take off or it were to be disseminated more broadly, it would have impact for a wide range of different clinical specialties or fields, and also other stakeholders like patients themselves and how they think about it. And within that, not that you asked that question, I think there's also variability. Some people say, my diagnosis is exactly what, their legacy diagnosis is exactly what captures their experience, and this sounds like we're doing violence to that. And other people say, my diagnosis never felt like it really captured my experience, and this is much better. And so you essentially have variability across all of these all the time, wherever you look.
Thank you.
Thank you.
Okay, that looks like that's all the questions. Thank you so much for a wonderful presentation. We appreciate you being here.
Thanks for having me.